Now we are doing diabetes insipidus. In diabetes insipidus, two types: central and nephrogenic. In central, it affects the brain. It will lead to low ADH secretion by the hypothalamus or defect in hypothalamus or pituitary. Low ADH secretion by pituitary gland. Nephrogenic will affect the kidney tubules, cannot respond to ADH. Causes of the central is idiopathic trauma or other destructive process. TB, infection, sarcoidosis, syphilis, encephalitis. And in nephrogenic, it will lead to chronic lithium, hypercalcemia, pyelonephritis, or the megalocylins. The factors which includes in nephrogenic diabetes insipidus is also the we use treatment for SIADH. The megalocylin is a drug which we use in SIADH syndrome. It acts on ADH receptor on aquaporin 2. Another is congenital, um, caused by mutation in ADH receptor gene on aquaporin 2 gene. Clinical feature is a polyuria, increase in urine production by 5 to 15 liter. Urine is colorless. There will be thirst, polydipsia. Hypernatremia is usually mild. Then with the investigation, we will do 4 investigation: urine investigation, plasma, water deprivation, dehydration test, and ADH level. Urine, we have the low specific gravity and low osmolality, means there will be more H2 and low sodium concentration in urine. Plasma osmolality will be increased because of increase in water excretion, and decrease sodium excretion will lead to increase in osmolality of plasma. Water deprivation test, dehydration test, and ADH level. ADH level will be low in central diabetes insipidus and normal or elevated in nephrogenic. Response to water deprivation test, we will have the in normal patients. Then we have the diabetes insipidus patients and nephrogenic diabetes insipidus patients. Normal patients, if normal patient experience dehydration, the urine osmolality increases. But in diabetes insipidus and nephrogenic diabetes insipidus, there will be no increase in urine osmolality. If we give an ADH, then diabetes insipidus patients will respond positive. There will be less excretion of water because central diabetes insipidus is caused by low ADH secretion by the posterior pituitary, but nephrogenic is not caused by low ADH secretion. It is caused by defective response of uh, collecting tubules by 2 ADH hormone. Then we have the management. In central, we will give desmopressin and chlorpropamide. And in nephrogenic, we treat with sodium restriction and thiazide diuretics. Sodium restriction and thiazide diuretics causes increased water absorption in the proximal tubules, and less will be go towards collecting tubules because the ADH and nephrogenic diabetes in central diabetes insipidus and nephrogenic. In central, the defect is low ADH. ADH is act on collecting distal collecting tubules, and nephrogenic this is defect in distal convoluted tubules. If we absorb more water in the proximal convoluted tubules, then blood plasma volume of water will increases because more absorption in the PCT and less we will go towards distal convoluted tubules.